Is he here? No. So welcome everyone to this session. It's a practical case-based workshop on the 2018 focused update of the CCS guidelines for the management of AF. We're going to have four faculty for this session. I will be chairing. Jason will be presenting on CAD. Brent will be presenting on cardioversion, and Alan on ablation in the context of heart failure. So as you know, there was a publication of in 2018, it was the AF update based on new evidence. So the AF Guidelines Committee every 2 years came up with updates based on new evidence that was available. These are the authors of the last edition of our updates. In the process of the CCS guidelines, we always have a secondary panel members that are responsible for reviewing the content of the update and the material that we provide, and they provide insight comments and to improve the content of the guidelines. So last time, so in 2018, and I need to remind you, there's no update this year, but we are working on a whole rewrite of the guidelines, which is scheduled for 2020. And at the end of this presentation, I will tell you how we're going to work for achieving this goal. So to go back on 2018, although there was no new documents since 2018, actually there was a paper written in the CJC to discuss about the cardioversion issue, which was a big issue, especially for the ED community as well as cardiologists. And there were a lot of new data regarding antithrombotic therapy in patients with AF and CAD. And there were trials in AF and HF that were published since the last time. So we thought that these three topics would fit very well into this session here. So we're going to focus on these three topics for the present session. So hopefully, if he gets here on time, the first session will be the first part of this session will be presented by Jason Andrade. He will discuss AF in the context of CAD. I don't know what happened. Sorry. And then Alan Scanes from London, Ontario, will discuss about AF ablation in the context of heart failure. And Brent will have 30 minutes to discuss cardioversion. So the time allowed was according to the lot of discussion that the topic brought since last year. And I will present to you at the end what we're planning for 2020. So we will use the CCS app for this session as well. There will be, it's a workshop based on cases. So we'll have cases with questions and of management of these cases. So please log on to the app. If you haven't done that, so you go to the CCC app, you find a session. Once you're in the session, you go to ARS, which is the audio response system, and then you can click. When there will be polling questions, you can access them on your iPhone or any phone you have. So we're going to go. Can we skip to?
Yes, we have no Jason.
Yes, we have no Jason. Oh, yes, we have a Jason coming in. He was in another session just before, so he had 3 sessions in a row. So we're keeping him busy. And so Jason will be responsible for the section of AF in the context of CAD.
Thank you. Sorry I'm late. I'm going to try and catch my breath here for a second. So fundamentally, in the guidelines, nothing's changed. The main thing that we wanted to present here is that the evidence has evolved, and in some ways, the evolution of the evidence has validated what we put in there in 2018. So, sorry, still out of breath. So when we think about the management of antithrombotic therapy for patients who have AF and coronary disease, essentially we're balancing 2 risks. So we balance the risk of stroke, and that's typically what we have within the CCS algorithm. And then we balance the risk of thrombotic coronary risk, and that typically comes down to the presentation. The cases I'm going to go through are essentially going to cover each of those presentations, and they highlight a point for each of them. So the first case we're looking at has to do with stable coronary disease in AF. And so this is a younger man, has had an MI in the past, has had a previous stent, is taking medications for the coronary disease, and now has non-valvular paroxysmal atrial fibrillation. So these are your options, and there will be a poll here on the next slide about what you think is the reasonable antithrombotic therapy to provide, and the option includes nothing. And I'll catch my breath while we go through that.
Can you remind the case?
Yeah. So the case, remember, is a 60-year-old with coronary disease and previous stent. And that's it in terms of risk factors. And so now they have atrial fibrillation. So no high blood pressure, no heart failure, no diabetes, no previous stroke. Okay. So options seems pretty even between it doesn't matter what NOAC you give and aspirin, and to a lesser extent we have variations on antiplatelet therapy, nothing, and dual pathway therapy. And so this would be sort of like your compass regimen of low-dose rivaroxaban plus aspirin. Okay, so the important point here is from an atrial fibrillation guidelines perspective in Canada, we do not consider coronary disease or peripheral arterial disease to be enough of a risk factor to warrant anticoagulation. So previously, we used the CHADS-VASc score. The CHADS-VASc score includes vascular disease as a stroke risk factor, and depending on your international society, would have recommended anticoagulation in someone who has vascular disease. The CCS 4 years ago, I believe, decided that the vascular disease component was not enough. And so if you look at this, having coronary disease increases the risk of stroke a little bit. Having had a previous MI increases the risk a little bit more. Having established peripheral arterial disease increases it a little bit more. But it doesn't quite crest over what we would consider to be the treatment initiation threshold. So the reason why we don't recommend anticoagulation in someone with vascular disease is the absolute risk increase by having vascular disease is relatively low. On the flip side, we know that anticoagulation is effective in this population, but because the absolute risk is low, that increased risk of bleeding that you see with anticoagulation therapy doesn't seem justified. And so for that reason, the CCS recommends antiplatelet therapy. Now the evolution, which I'm going to go one more slide forward, from 2012 to 2016 and then into 2018 was there were now more options for antiplatelet therapy. So where we previously recommended aspirin, we're basically now saying do whatever you would do for their vascular disease. If that's aspirin alone, great. If they're after a stent and you want to keep them on ticagrelor and aspirin, sure. If you want to give them vascular dose rivaroxaban with aspirin, fine. But you're doing that for their vascular disease. You're not doing that for their atrial fibrillation. The benefit to the atrial fibrillation is that those therapies do have an element of stroke reduction. So if you look at that rightmost column, aspirin alone reduces the risk by about 20%, aspirin plus Plavix, 23%, aspirin plus ticagrelor, 25%, the vascular dose of rivaroxaban plus aspirin, 40%. So you will get a side benefit of reducing the risk of stroke, but you're giving the therapy for the vascular disease. Okay, so in that case, now say the person's 65. Totally different picture. So now if they're 65, their risk of stroke is now high enough that anticoagulation is beneficial. That person who's 65, despite everything else being the same, now needs to be anticoagulated. If you look elsewhere in the guidelines, when we look at the post-PCI or the patient with stable coronary disease, in the AF guidelines, we recommend anticoagulation alone as the preferred therapy for this group. And this is, again, stable coronary or stable peripheral arterial disease. The rationale underpinning this is that we know that antiplatelet therapy is good in coronary patients at treating coronary outcomes. So your relative risk reduction is about 20%. But in patients with coronary disease, if you give them oral anticoagulation, so these studies are in the era of warfarin, warfarin is more effective than aspirin at treating their coronary disease. We don't give warfarin for coronary disease clinically because it's a pain and because there's a bigger risk of bleeding. But you should be reassured that warfarin or anticoagulation is an effective treatment of their coronary disease. Now, why don't we say add aspirin? Because if you add aspirin to warfarin in coronary patients, all you do is increase the risk of bleeding without any tangible benefit on the coronary outcomes. So in these two older studies, WARIS-2 and ASPECT-2, you see that the addition of aspirin in terms of their death, stroke, or MI rates, you got no benefit by adding the aspirin. In the past year, there's been a recent study published looking at a randomized study of rivaroxaban versus rivaroxaban plus aspirin in patients with stable coronary disease. So these are more than 12 months post-intervention. In this study, patients were randomized. And what you saw was exactly the same thing that we already knew. Combination therapy, adding aspirin to the rivaroxaban, increases the risk of bleeding, basically doubles the risk of bleeding over using rivaroxaban alone. So there's a harm in adding the aspirin for stable coronary disease. The bigger harm, though, is that the risk of hemorrhagic stroke was substantially increased. So you had a 70% reduction by dropping the aspirin. The risk of cardiovascular death also increased. The risk of non-cardiovascular death also increased. So now not only is it bleeding that you're causing, but your patients are actually dying more if you add aspirin to the anticoagulation alone. So in an AF patient with stable cardiovascular disease who needs to be anticoagulated for their AF, just give them the anticoagulation. You don't need to add in an antiplatelet. So, third case, same patient again, but now they're 3 years older, they've got high blood pressure, and so they start to develop angina. You give them anti-anginal therapies. You do a MIBI, it's ischemia, you send them for an angiogram, they have significant coronary disease, and now they get stented. So this is a bit of a different presentation. Going back to the very beginning, again, we're balancing the risks of stroke prevention with the anticoagulation against the risks of stent or repeat MI outcomes with the antiplatelet agents. And so this is where it gets very much into the weeds. And so the first thing is just philosophically, what are we going to pick? So do we give them dual antiplatelet? Do we give them anticoagulation plus a single antiplatelet? Do we give them anticoagulation plus dual antiplatelet? So it's called triple therapy. If we do this, so what are we going to pick? Are we going to use warfarin? Are we going to use any NOAC? Are we going to use a specific NOAC? What are we going to use for the antiplatelet? Are we going to use clopidogrel? Are we going to use prasugrel? Are we going to use ticagrelor? And then how long are we going to have combination therapy on? Is it 1 month? Is it 3 months? Is it 6? Is it 12? So this is where it gets very, very complex very, very quickly. And I don't know that there's any perfectly right answers for all patients. Again, if we look at the evolution of the AF guidelines, back in 2012, we divided it by ACS or PCI. In 2016, it got a little bit more nuanced. In 2018, we contracted back to something that we thought was just a little bit clearer for the clinicians. And so if it's elective, if it's not high-risk features, you go down the pathway of dual pathway therapy. If it's high-risk PCI and ACS, then you're starting off with triple therapy for some duration, stepping back to dual therapy, and then when they become stable coronary disease again, you go back to anticoagulation alone. The reason why, and so this accounts for a little bit of the update, or at least the updated evidence since we published it, is that we know that dropping the aspirin, so going from triple therapy down to dual therapy, is associated with significantly less bleeding. So the WOOS study is sort of the landmark study that started us down this path. So it was warfarin, or a vitamin K antagonist, randomizing out the aspirin and showing that at a year there was significantly less bleeding. At the time our guideline was written, the pioneer study of rivaroxaban was published, and the redual study of dabigatran was published. So then that made it into the guideline and informed our decision. Since the guideline was updated, Entrust of edoxaban has come out, and then Augustus of apixaban has come out. And you can see that the idea of getting away from triple therapy seems to be mostly associated with benefit in terms of the bleeding risk. If you take all those studies together, in a meta-analysis, it's about a 40% reduction by using NOAC dual therapy against vitamin K antagonist triple therapy. The stroke risk is neutral or trending towards some benefit by using the dual pathway therapy, so we're not compromising by losing the aspirin. In terms of all-cause mortality, it's fairly neutral, but trending a little bit on the higher side in terms of the vitamin K triple therapy. But where you start to have some worry is around those with the repeat infarction and stent thrombosis risk. So those seem to have a little bit of benefit if you retain the triple therapy rather than going right to dual pathway therapy. And so if you put that together, what our guideline had recommended was that patients who are at high risk of a thrombotic event, so I've listed them on a slide, I won't read them, but they're present in the guidelines. Those are the people where we're more worried about that MI outcome or that stent thrombosis outcome. And so those are the people where a period of triple therapy is probably beneficial rather than stepping right down to the dual pathway therapy. On the flip side, if someone does not have all those high-risk thrombotic outcomes or predictors of thrombotic outcome, and maybe they're at higher risk of bleeding, then maybe we step down right away. And so this is where clinical judgment fits into the guidelines, where I say that there's no sort of one-size-fits-all approach for everyone. If we think about which anticoagulation should be part of the combination therapy, the guidelines takes no position on this, so we basically recommend a NOAC over warfarin because there's benefit with a NOAC rather than warfarin, but we don't go so far as to specify one NOAC over another. There's no head-to-head trials, so it becomes very difficult to make that comparison. All we do is provide you with what we consider to be the studied regimens. On the flip side, we recommend that clopidogrel be the preferred antiplatelet agent used in combination therapy. So this is just an overview of all of the different trials. You don't need to look at that necessarily, but typically more than 90% of the studied regimens were clopidogrel based. So the idea that we can use ticagrelor is a bit challenging because it was used in around 5 or 6% of all of these studied patients. Prasugrel's even less. So it's hard to know if that bleeding benefit holds when we're using things like prasugrel ticagrelor. In terms of the duration of triple therapy, again, this is a bit of an open question, and I think it falls back more to our interventional colleagues focusing on sort of the stent and the anatomic risk, determining whether that risk is front-loaded, or sorry, the risk is front-loaded, so whether or not we can truncate it short or truncate it long. ISAR triple is a study basically of short duration versus long duration triple therapy. And what they showed was that there was no hit by limiting the duration of triple therapy, but there was a benefit in terms of the bleeding risk. So again, the less exposure someone has to triple therapy, probably the better they are in the long run. And we don't seem to cause any thrombotic harm by limiting that. So in conclusion, the way our two flow tables are structured are such that we always start with the CCS algorithm, or sort of the CHAD65 score. If they have any risk factor for stroke, then we recommend that they be anticoagulated. If they have no risk factors for stroke, then we do not recommend anticoagulation for the purposes of stroke prevention. If they have vascular disease, just treat the vascular disease like you would. Otherwise, don't give them anything. In patients who have an indication for anticoagulation, then you treat their coronary disease depending on their presentation. So if they have stable coronary disease, we don't recommend combination therapy. We recommend anticoagulation alone. If they have an unstable coronary syndrome or they have an elective PCI, then the combination therapy depends on how high risk they are in terms of whether or not you use triple therapy or not. One of the things I didn't include here is that each of those randomized trials included a period of triple therapy at the beginning. So Augustus, it was almost a week before they were randomized and dropped their aspirin. The exact same thing holds for all of the studies. So everyone is getting aspirin on the day of their PCI, and then it's up to the interventionalist how long that should be. So if you look down that middle column on the right slide within the red box, we say 1 day to 6 months, and that's largely going to be dictated to us by our interventional colleagues. The other thing that I didn't bring up in this presentation is that the ACS without PCI. So this was a bit of a contentious topic over the past few years because we didn't really have any evidence to inform our recommendation. We were doing this as an analogy, and we were saying that if anticoagulant is a substitute for aspirin, if you medically treat an MI, aspirin and clopidogrel is better than, say, aspirin alone. And so if we're substituting out the aspirin for an anticoagulant because they have AF, then the two together should be the preferred approach. We can now say that with Augustus being published, Augustus did have about 30% of their patients with medically managed MI, so no PCI, and they showed the same benefit. So again, we were a bit ahead of the curve in the recommendations that we made, and I think that we've been validated in those two contentious areas in terms of our current recommendations.
Thank you, Jason. So there are questions for you. So you alluded to that, talking about the duration of aspirin in the triple therapy regimen. So you mentioned that in the Augustus, the mean was 6 days up to a week before being randomized. And the related question is, what's the point of 1 day of aspirin? Is there a biological plausibility for that?
I don't know that I can get to the biological plausibility. I mean, I think it just comes down to the 1 day is meant to protect you during your intervention, right? So as an electrophysiologist, we give aspirin on the day of ablation. We don't give aspirin long-term for ablation. Like, we just do it the day of because we're angering the platelets by putting non-natural products in the body and then sort of banging around in there. So I think that there if you're presenting with an ACS, you have a ruptured plaque, you have inflammation that's active, you have you have platelets that are angry, you do everything you can to protect it, and then the question is, do you drop it afterwards? And so if you irreversibly block all the platelets, then do you need to continue it on long term? Probably not. But the question around that high-risk period, you want to do everything that you can, and then when you're into a more stable period, that's when you start to back off. And so, I had a slide that I'll show, I think probably Saturday, that takes a little bit more detail into this. So it's typically around 48 hours up to a week when that randomization happens. And really, that's your index hospitalization after an ACS. So most of the time, practically speaking, I think you're going to end up with triple therapy for an ACS during the time that they're hospitalized. And then mostly the aspirin's going to get dropped, and you're going to end up on dual pathway. And whether that's 6 months or 12 months depends entirely on the anatomic period, or the anatomic considerations and the patient considerations.
Another question is, if there was an apical thrombus, would your choice of anticoagulant change?
So luckily, half an hour ago, I was in a different session, and this was asked to Sean Goodman, and he answered the question. Unluckily, I've forgotten his answer. So what Paul Dorian said was it depends on the type of thrombus. So if you're talking about fresh thrombus, then yes, you have to anticoagulate them. If it's layered or sessile thrombus a year later, then you wouldn't anticoagulate that anyway. The big question just comes down to risk and benefit. I don't know that we have any evidence that actually informs this, which is why it's kind of just us postulating. The question that I always have, and this is probably outside of the purview of this forum, is if there is established clot, whether preventative stroke prevention dosing of anticoagulant is enough, or if we have to think about other dosing. Because the dosing is not always the same for a DVT or a PE in the front-loaded period versus if you're trying to prevent that, say you're trying to prevent an AF-associated stroke. I can say that experience with various people gives us various answers. I don't know that we have proof one way or the other. I think that it's reasonable to use the thing that you think is the most reasonable thing. But, evidence is probably best for warfarin in that circumstance.
Thank you. So we'll switch to the topic of AF ablation and heart failure, and Alan Skeins from Western University in London will discuss that based on a case.
Thank you very much, Laurent. Thank you, Jason. There's nothing more nerve-wracking than being late for your own session, dashing in here, coming to the podium, taking a deep breath, and doing your talk. So, well done. Yeah, thank you. Do I have to click on my slides?
I don't know who's going the audiovisual, but you don't need to restart. It's a whole presentation all under Alan Skeins. So go to start.
You want me to go start again?
Yeah, and you flip down to your slides.
Great. Okay, got it.
You can do that with your remote.
Oh, can you? Oh, very good. This is why you're the chair.
Not faster, actually. So please, for the next
Oh,
presentation,
that's
just leave it there.
Okay, good, thank you. So I'm going to make you hopefully think a little bit as we move through this case together. I'll get right into it. I'm always troubled about whether we should read these or whether you read them faster than me. You can see a lot of the details. This is a 58-year-old woman with recurrent AF and heart failure. It starts in 2010 with the first episode, and actually she had a little bit of heart failure at that time. She underwent DC cardioversion early on, did well for 3 years. And then again, 3 years later, you can see she had another episode of atrial fibrillation in the emergency department. She had some dyspnea over the next 5 to 7 days, leading up to her emergency room visit. And as I'll show you on the next slide, her ECG showed rapid A-Fib and left bundle branch block. Now, she was not on an anticoagulant, and you might notice in the first line she had had congestive heart failure, and as you just heard, perhaps she should have been. But as you'll also read, she also likes to manage her own medical affairs. So she was actually on aspirin, Lipitor, and sometimes metoprolol, depending on when she would want to take it. Patients sometimes are like that. There was no other significant past medical history, and you can see her CHAD score is 1. Here's her ECG, rapid, irregular. In the top right, I left you the details. 121 is the beats per minute, wide QRS, left bundle branch block, as advertised. So a little bit about her vitals. You can read her blood pressure is a little bit low. She's on oxygen. She has signs of congestive heart failure. JVP is up, bilateral crackles, ankle edema. To the extent I can still find an apex, it was enlarged. And you can see her creatinine was up and her GFR was a bit borderline, and that might be important as we move on. You can see also her chest x-ray confirmed what we thought clinically. Her echo shows a mildly dilated LV with a low EF, and her LA was not particularly enlarged. So, since this is meant to be a workshop, I wanted to ask you, anybody do POCUS or point of care ultrasound in their institutions? Just show me some hands. Good, okay, this is mostly to know if you're awake. So thank you. So point of care ultrasound was done. In our institution, we have someone who loves this, and everybody does point of care ultrasound. That's what POCUS is. You can see this. What this means is it confirms what we have clinically, that she's volume overloaded, okay? So here's the question. She's admitted to the CCU. She's given IV Lasix. Those things are straightforward. She started on some apixaban. And then what else would you add to this lady's care? So she's fast, she's in congestive heart failure, and her blood pressure is about 95-ish. So I push one more. And you get to vote. Vote early, vote often. I'm particularly interested in what Dr. D voted. Where is he? Stop moving? Okay, good. So there's a number of ways that this case can play out. And at the present time, I think most of us are a little unsure whether this presents as rapid A-Fib and tachycardia-induced cardiomyopathy. With the history of A-Fib, that makes sense, and rate control is our best approach. Alternatively, this might be a lady who has bad cardiomyopathy and secondary atrial fibrillation. So we're going to learn pretty quickly as we start rate controlling this lady, one of two things is going to happen. Either she's going to slow down and do well, or occasionally we slow these patients down, they're refractory, and they end up in a bad way on milrinone. So there's a number of different ways to do this. I put this up to challenge you a bit, so my comments. I put specifically bisoprolol up there because it has a long half-life, and it may not be the most advantageous agent. So it's going to take several days to kind of get into her system. And if she's really tachy and really heart failure, it may not be the most effective early therapy for this patient. So intravenous therapy is probably the way to go. And I gave you two difficult choices on the intravenous therapy. So in our world, esmolol gets given very little. There are critical care patients that we use IV esmolol only because it's a beta blocker that's easily titrated on, titrated off if patients get really sick. So you might start beta blocker, and this lady might do very poorly, hypotensive, anuric, etc. In our setting, we'd probably use IV amiodarone. So another question to see if you're awake, how many in your center have access to transesophageal echo to make sure there's no clots? Few. So the other dilemma here is, well, if I start an antiarrhythmic and the patient could have a clot and I can't get a transesophageal echo, what do I do? So that's why these dilemmas are there. DC cardioversion, same sort of dilemma. Could the lady have a clot? Does she need a TE? That sort of thing. In our institution, we have access. We started IV amiodarone and did a TE within the first 24, 48 hours, and that's how we manage her. But I understand there's lots of other challenges. My only thought would be if you start a beta blocker, try to use a short-acting beta blocker, and consider at least some IV therapy if you're worried about this lady. Okay? So, as I mentioned, we started IV amiodarone. We usually start 35 or 50 milligrams an hour and titrate to slower heart rate. And what was nice about this is as we slowed her down, her heart rate improved. We did a TEE in the next day or two to rule out a thrombus. She was already on anticoagulants. And you can see what we managed. And as this lady turned out to have predominantly a tachycardia-induced cardiomyopathy, or at least some of it, that when we slowed her down, her EF improved, as you can see. So she was loaded up with oral amiodarone, and this is one approach. And an outpatient cardioversion was arranged for this lady in a month. So she does well for 5 months. She's in normal rhythm. Her echo improves a bit further, not normal, but it's a bit better, although she's still having recurrent atrial fibrillation despite the amiodarone. So now she's slower, but she's still having heart failure. She's still having NYHA class 2 symptoms, in and out of the rhythm. And now what would you do?
So far, so good. They've read your title.
I'm not sure that's the right answer. It'd be nice to know how many people have voted, to know whether this is 3 or 10 or 100.
101 are online.
Has everybody voted? I'm not sure there's a right answer. Pick one. Okay, everybody loves AF ablation. I love AF ablation, but there are many different ways you can go with this. So let's talk about each of these. Repeat cardioversion. I think that's a reasonable approach, in fact. It would kick the can down the road a bit because she's going to come back again with more fib. So maybe not the most preferred. She's a young lady. You're going to expose her to lifelong amiodarone. Maybe you stop it and just leave her on rate control. We'll see some data in a minute that addresses whether rhythm control or rate control is better. We'll discuss that. Stop the amiodarone and AV node ablation. She has left bundle, so we're talking CRT. That might be a reasonable approach. She's a bit young for that. Or atrial fibrillation ablation, which you guys all prefer. Let's talk about this. The last thing is, the other question is, are there any other tests that might be helpful? This is not a poll question, but I do want to ask you that, and I'll briefly mention that. Oh. So if we go back to 2008, which was 10 years ago, the AFCHF trial looked at what to do for patients with A-Fib and heart failure. And at that time, A-Fib ablation was not a strong moving strategy for these patients. So the vast majority of these patients got amiodarone in the rhythm group, rate control in the other group. They're followed, and you can see the event-free survival, no difference. When we looked at worsening heart failure, no difference. So it became clear at this time that the way we were doing rhythm control for these patients was not benefiting them beyond symptom management. And you can see a meta-analysis of all the trials around this time showed, lumping them all together, we weren't making a mortality benefit by trying to do rhythm control. Vast majority drugs, almost no ablation. Shortly after that, there became a number of meta-analyses, and I'll show you one. This is based on 26 observational studies that looked at patients who had undergone ablation or had not undergone ablation, and you can look at what happens to their ejection fractions. So in the top two bars, their ejection fraction, those that are less than 35% went down dramatically. So before ablation, a quarter of patients had poor ejection fraction, down to 10% afterwards. And likewise, if you look at the ejection fraction before ablation and after ablation, there seemed to be an impact. And these are all patients that were adequately rate controlled. What we've done is rhythm control them with a strategy that didn't include amiodarone. So this is a piece of provocative data that maybe rhythm control might provide some benefit over rate control. This is a trial, a summary of a number of prospective trials done. And you can see, if you look carefully, I apologize for the slide, the sum total of data is, as you can see, 6 or 7 trials that look at a number of different outcomes. If we look at the bottom, for the most part, they all have slightly different ways to approach the patients in the control arm, but the ablation arm is the other major comparator. And the ejection fractions across the board seem to improve. 6-minute walk test tended to improve. And in fact, if you look at some of the other end outcomes on the right half of the slide, there is some benefit in heart outcomes as well. So this is a bit provocative that maybe ablation doing something beyond what could be achieved with amiodarone. Cassoulet F was the study that really brought this to the forefront, and it's the last one in that column. It was a large randomized controlled trial published in New England Journal, 363 patients, and you can see the inclusion criteria is a bit soft. Those who had failed or would not take antiarrhythmic drugs, and they were randomized to either medical therapy, which was usually rate control, or catheter ablation. They all had poor ejection fractions, they all had poor NYHA class, they all had an ICD with an atrial lead so we could see how much atrial fibrillation they were having. And the usual outcome we've been looking at is a composite of all-cause mortality or heart failure hospitalization. And shocking for many of us, this study showed a major difference. The type is small, but the primary endpoint was statistically better with ablation, and all of the secondary outcomes, or virtually all, were better with ablation. The one that wasn't was hospitalization for any cause, not surprisingly, not different. So this really threw a large signal into the blogosphere, or Twittersphere, I guess it is now. I'm showing my age. About these patients and what we should be doing them, and there was quite a bit of discussion that occurred. I want to show you a couple of details, and then I want to show you a little bit of criticism. So when they looked at death or hospitalization, ablation did better. When they did hospitalization for worsening heart failure, you can see the reduction, almost 50% reduction. If you've not read this article, I think it's worth reading. Milton Packer is a very well-known heart failure physician who wrote this editorial, and the title is provocative, Building Castles. Remember, the study is called Cassoulet F, Building Castles in the Sky. Catheter ablation in patients with atrial fibrillation and chronic heart failure. And he laid out what was a pretty well-constructed criticism of this study. So there was use of what's called a modified intention to treat. There was imbalances between baseline characteristics, meaning the heart failure patients were treated differently. Rather than everybody getting optimized up front, only the ablation arm seemed to get ongoing management optimization, or at least there were concerns about that. There was concerns of adequacy of the heart failure treatment in each arm, and were they the same? There were some balances and some censoring, and if you read this study, you'll find out that the authors of this, who are heavy hitters in the heart failure world, said there is no other way to interpret this study except as hypothesis generating only. So this is rather scathing feedback for our side of the business. Interestingly, about the same time, there was a small study from Australia, and you'll see that there's only a small number of patients in this study, but it took a mechanistic question. Same group of patients using MRI scans, and you can see on the left, it looked at the absolute change in EF from baseline, whether you got catheter ablation or medical rate control, and prospectively re-demonstrated this dramatic change in ejection fraction. What was interesting is when you looked at the patients, they were in every way excellent medical management. So there's the demographics, the standard patients who we would ablate. And importantly, the rate control was excellent in both groups. If you wanted to mess up the study, leave the rate control arm fast, and they would do less well. But here you can see the rate control in both arms absolutely excellent. The ejection fractions at baseline on cardiac MRI are the same, and you can see something important. The very bottom row, late gadolinium enhancement. We give gadolinium, it washes in, and when it stays around, it is a marker of fibrosis or scar. The idea being, if those patients have ejection fractions that's low because they have lots of scar, it's not likely going to get better with ablation. Whereas if they have minimal scar and low EF, maybe those are a group of patients that might do even better if we could slow them down further. And in this slide, they looked exactly at that, and they found that the patients who were LGE negative, that's the orange bar, had a much greater improvement in their ejection fraction. And you can see that the number is 22% on an ejection fraction, huge. Small numbers of patients, but a really impressive signal. On the right, you can see the more fibrosis, the less improvement in their ejection fraction. So we're actually doing a study called Raft AF. It is going to finish enrollment in February. We're already starting follow-up. Some of these patients we've been following for 4 to 5 years. Cassoulet F, but in a Canadian environment, rigid inclusion. So all of those limitations, or most of them, are going to be diminished. And you can see where we're going with these patients. Importantly, the rate control arm has lots of atrial fibrillation, as we'd expect. And the rhythm control arm, despite being sick patients, seem to be doing well, so that we've got an 82% difference in fibrillation rates between the two arms. So this is going to be very interesting when we get this to determine whether this is a real signal or whether this isn't a real signal. And until then, the guidelines committee have been a little bit reticent to jump onto the Cassoulet bandwagon. And this is the relevant guideline. As you can see, halfway through the box, with mild to moderate structural heart disease who are refractory or intolerant to one antiarrhythmic medication, a weak recommendation. So we've not made it a strong recommendation. We're waiting for more data because we do have some reticence about the Cassoulet study. And I'll stop there.
Thank you. So we have some questions for you. The first one relates to the TEE timing versus AMU IV.
Yeah, so that's a great question. You know, practically life is the way it is. So I would love to be able to call up somebody to get a TE today, tomorrow. The conversion rate with atrial fibrillation to sinus rhythm is not great. In the emergency department, it takes 8 to 12 hours to have any signal above placebo. So in a heart failure patient who's likely not going to convert, we encourage our guys to do it as soon as possible, but we're not as fussed if they can't do it in, right away. So a day or two.
So should we order cardiac MRI in patients who present in AF and CHF?
That is a great question, and I'd love, so the real question is, just poll the audience, who has MRI access in their center? So from our point of view, that is the minority of patients. So I think that's the issue. Maybe if we had a better test that could give the same signal in a different way, we're looking at strain rates and echo and things like that. But sure, if this was an ideal world, wouldn't it be great?
Last one for you. To consider PVI for symptoms in the context of heart failure, do you consider heart failure a symptom or you wait for palpitations?
Yeah, that's a very, very good question. We individualize care, and there are lots of patients like this lady who you get the feeling that the A-Fib is the major driver of the heart failure by history and looking at the sum total, and we'd probably be a bit more on the ablation side. If someone presented with heart failure, and incidentally found an A-Fib, a lot less excited, and anybody with ancillary symptoms like palpitations and that sort of thing, we're a bit more aggressive with.
Excellent. And sometimes we can use cardioversion to see if it makes a difference.
So that is sometimes our arbiter when we're stuck and we don't know. If you cardiovert patients and give them a protracted period of sinus rhythm, which is not always easy, they can sometimes tell you, and they say they don't know they're in fib or they're not, then probably that's not a patient who's going to do well.
So there's a question, and I'm going to ask you a related question. So given the LV function in your case was reduced with the LA size normal, would you consider this to be primarily cardiomyopathy, then AF? And my second question related to that, if we relate to the Cassoulet F study, were there mainly patients with heart failure developing AF or patients with AF developing heart failure?
Yeah, so the case had a couple of things. The LV was small and the LA was small, suggesting that this was a subacute process and probably rate related, and that's how it bore out. That's a couple of the markers that might help you decide. Cassoulet F, I don't know that we know for sure what those patients were. They had low ejection fractions and ICDs placed as primary prevention for their LV dysfunction. So presumably they were good-going heart failure in addition to their A-Fib.
And the last one, and I'll let you breathe after that. Can you comment on how age is factoring into your decision of rate versus rhythm, including ablation?
Yeah. Let me take the extremes, because that's easy. The older patients, and by age I don't mean their chronometer, their odometer, I mean their biologic age. Someone who's older, a bit frailer, many comorbidities, AV junction ablation is probably a reasonable way to go. And in this case, that might be the case if this lady was 78 or 88. And the younger they are, the more we go towards ablation, because settling that patient or saddling them with a device for many decades is not nearly as appealing. And then in between, we personalize it.
And a very interesting question. Let's say you have tachy-mediated tachycardiomyopathy, all right? So AF recovers completely after cardioversion. Then this patient goes back into AF later on. Yeah. And EF drops again.
Yes.
Is that an incentive for ablation in that patient?
Yeah, I think so. It's certainly an incentive to try to get either very aggressive rate control or probably rhythm control with amiodarone or ablation or both. And sometimes we've done both. You've done a couple of ablations and a little bit of amiodarone, knowing they've shown you a couple of times that their EF is going to fall off precipitously. Or that's someone you end up in AV junction ablation, CRT, down the track as well, depending on how the other comorbidities are.
Depending on the comorbidities, yes. Thank you. That's a great question. So, thank you, Alan. So last but not the least.
You're the last.
Yeah, I'm just having 2 minutes. So cardioversion of acute AF in the ER.
Despite the title, I don't want you to focus on the ER. It's really in the acute care setting. People who present with atrial fibrillation with the expectation that you're going to do something about it right now. That will often be the emergency department, but not always. And yes, indeed, it's a pleasure to be here. My name is L. Brent Mitchell. Please don't call your children by their middle name. It causes nothing but grief. Everybody thinks I'm Spanish. El Brent. I'm going to try to do 4 cases, but if we only get to 3, the only person that will mind is Jan, because the fourth patient is just for her. This is the only patient I've ever looked after whose name is Hercules. That's why I picked him, of course. It has nothing to do with the hat. He's a 69-year-old male. It won't surprise you that he's from Greece. Has a 20-year history of treated hypertension, a 2-year history of paroxysmal atrial fib, no known structural heart disease, no other health issues, comes to the emergency department with palpitations and shortness of breath that began about a week ago. He's on atorvastatin, ramipril, metoprolol, and aspirin. He has atrial fibrillation, as you will all recognize. Particularly in V1, you can see the baseline undulations that are ultra rapid and varying in morphology and timing. And we even have one neat right bundle branch block Ashman phenomenon. Other things you might be interested in: his blood pressure is maintained, his heart rate is rapid and irregularly irregular, but not terribly rapid. And those are the other things that people wonder about that won't be of any importance in this presentation, except that his eGFR really should be estimated creatinine clearance is well maintained. So in summary, he's a 69-year-old man, the CHAD 62 number of 2, who's had atrial fibrillation symptoms for 1 week, is hemodynamically stable and not rate controlled. So this is your first question. This one, like all first questions, is easy, right? I always tell the students, if you're in a group and you're being asked questions, answer the first one. Then it's somebody else's turn because the questions get harder and harder. So you're voting away. And yes, indeed, this should be relatively obvious, and that is the correct answer is the man needs to be anticoagulated. So you're only talking about the bottom 3 answers. And then the question becomes, is he eligible for immediate cardioversion? And the answer, as you will see, is only after 3 weeks or after a transesophageal echo. So the correct answers are either 5 or 6, depending on your outlook. Just to remind you where we're sitting with this question is not the end-all and be-all of the treatment of a person with atrial fibrillation in the acute care setting. First, we make a diagnosis of atrial fibrillation, and then we document that diagnosis. It is astonishing to me how often I'm asked to see a person who had atrial fibrillation that was treated in the emergency department and no ECG has been done. That's criminal. For I have seen people shocked under the guise of atrial fibrillation for sinus tachycardia, for SVT, for multifocal atrial tachycardia, and even once for VT. Not that the cardioversion was incorrect, the diagnosis was. We assess the hemodynamic consequences of that episode of atrial fibrillation. We ask why and why now. That's where we think about things like hyperthyroidism, pulmonary embolus, etc. Optimize the treatment of the cause of this episode and its underlying structural heart disease. Then we determine if antithrombotic therapy is needed, if rate control is needed, if rhythm control is appropriate. We then do all of those things and document that we achieved the goals. So, relative to this patient, the guidelines list the 2-3-4 rule. The 2-3-4 rule says that patients with more than 48 hours of atrial fibrillation or flutter, the majority of them that are stable should undergo electrical or pharmacological cardioversion only after they have been receiving therapeutic anticoagulation for 3 weeks before the cardioversion and at least 4 weeks after. In addition to the 2-3-4 rule, this guideline has some other important pieces of information in it. One is that we don't treat atrial fibrillation differently based on whether it's paroxysmal, permanent, or persistent. Secondly, we consider atrial flutter is equivalent to atrial fibrillation. Thirdly, we consider electrical cardioversion, pharmacological cardioversion to be equivalent to electrical cardioversion. And also, there's one important thing that's not there. The guideline is silent about spontaneous cardioversion because we really don't know what to do. What is interesting is what is this rule based on? It is based on 2 people's opinion. When the guidelines were first promulgated here in 1980, there was actually almost no data. This is the opinion of Bernard Lown. Anticoagulation prior to cardioversion is unnecessary if its duration has been less than a week. Otherwise, italics are mine, we routinely anticoagulate patients for a period of 3 weeks prior to cardioversion. Following cardioversion, anticoagulation is maintained for 1 month. That's where the rule came from, at least in its beginning. It was formalized as a guideline by Dr. Lapakis, who said, who corrected it to include the 2 for 2-3-4. He shortened the duration of the acute onset to 48 hours. 2 days, that's where the 2 comes from, based on, and the rest is a direct quote, the implicit assumption that there has been insufficient time for thrombus formation to have occurred in the atria. There are, unfortunately, no reliable data to support this assumption. That will become critically important when we get to the acute atrial fibrillator, that who has been in atrial fibrillation for less than 48 hours. But for this case, it just set up a standard of practice that has now been underway for 40 years. And these are the results of applying that rule. Shown on your left, historical data. 16 studies, all performed before 1970, involving over 2,500 patients. If you are not anticoagulated, the probability in the next 30 days that you will experience a systemic thromboembolic complication is 1.76%. If you are on anticoagulation, that risk is reduced by 74%, 0.45. It patterns the randomized trials that were performed in people that had longer-lasting atrial fibrillation and were not undergoing cardioversion at all. Just to make sure that that data is not biased by being old, we looked at another 10 studies performed between 86 and 2003. The results are essentially the same. So because of that apparent benefit, despite the fact it's never been subjected to a randomized clinical trial, we make the strong recommendation that the 2-3-4 rule applies to Hercules because he has been in atrial fibrillation for more than 48 hours, and in particular because it's true that he has a CHADS-2 score of 2. I'm going to change Hercules' history now to make it more relevant to the acute care setting, and that is the only difference is he's been in atrial fibrillation for 36 hours. Otherwise, it's the same case. Same question with the same responses. Please vote. So given that he is a CHADS-2, he needs anticoagulation. So the first three choices are not appropriate anymore. The next three choices then ask the question, can he be cardioverted immediately? Or does he need to be inspected with a TEE or go home for somebody to wait 3 weeks? The answer to that question until 2018 was any of the bottom three were acceptable. In 2018, based on new data, the committee changed its position in this regard, and this is the new bit. So which patients with acute atrial fibrillation or flutter may have a cardioversion without prior anticoagulation? We suggest that those patients are the 2 dots. Patients with non-valvular atrial fibrillation who present within 12 hours now, not 48, in the absence of a recent stroke or TIA, because the people who have had a recent stroke or TIA are already at so high risk that they shouldn't be anticoagulated they shouldn't be cardioverted without anticoagulation immediately under any circumstances. And the second group is a low-risk group defined as those with non-valvular atrial fibrillation and a CHADS-2 score of less than 12 hours. They can present after a score less than 2. They can present after 12 hours, but within 48. So that seems a little complicated, but what it's trying to do is say, cardioversion of the patient who presents with acute atrial fibrillation, that is that which has been in place for less than 48 hours, is not necessarily safe. And we should only be cardioverting the ones who are at lower risk. Where does that data come from? Well, first, there is some biologic rationale. Also on your left, the upper graph shows a measure of platelet. What was the word you used? Anger. A measure of platelet anger. And on the bottom of the left column is a measure of activation of the coagulation cascade. There's the 12-hour mark, and you can see that platelets are very activated, angry, by 12 hours, and the coagulation cascade is activated by atrial fibrillation itself within hours, maybe even minutes. The middle column measures left atrial appendage emptying velocity, and we can see in the blue column that it's normal in sinus rhythm. The presence of atrial fibrillation drops it by about a third. The performance of cardioversion, drug or electricity, immediately drops it by another third. So in the immediate post-cardioversion period, the emptying velocity of the left atrial appendage actually drops further and then doesn't recover for a period of time. How long a period of time is not relevant to this conversation, but it is relevant to other conversations. It seems to be about as long as the atrial fibrillation had been there in the first place. Just to show that this is important, the last column shows 3 transesophageal echo studies wherein people presenting in less than 48 hours after the onset of their atrial fibrillation had a TEE performed. How many had a left atrial clot? 10%, 14%, or 4%, depending on which study. Those are all really scary numbers if you're about to do a cardioversion without protection. 3 studies have actually now, in an observational format, asked the question, does anticoagulation make a difference to this? The anticoagulation registry was performed in Germany. Anticoagulation of patients with acute atrial fibrillation, if a patient had a cardioversion under anticoagulation, their probability of having a thromboembolic event in the next 30 days dropped by 71%. On the far right, you know, when I took my driving test at age 18, I failed it. The reason I failed is the guy said, turn right at the next intersection, and I turned left. Well, I have trouble with right and left. Right. Study from the Cleveland Clinic showing the same thing. Middle one is the important one. A lot of data came from the FIN-CV study of 7,650 patients who underwent, or 7,650 cardioversions of acute atrial fibrillation. Showed a massive reduction if these patients were anticoagulated. The green bit on this slide you've already seen. That's the modern data of chronic atrial fibrillation cardioversion. The purple is just a summed average of the previous slides' 3 studies. And you can see that, yes, indeed, patients with short duration atrial fibrillation do appear to be at lower risk than patients with longer duration. But that risk is still pretty high and is still substantially reduced by anticoagulation. How low do you have to go before it's not important? The Canadian Cardiovascular Society took a stance on this years ago, and we suggested that if your annual risk of a thromboembolic event was more than 1.5%, then the risks of true anticoagulation made sense with respect to the reduction in stroke that accompanied anticoagulation. 1.5% per year divided by 12 is 1.25% per month, which is what that red line says. 0.76, the risk of the unanticoagulated patient, is 6 times that high. Seems like we might want to consider anticoagulating these people. Well, can we parse that risk? Can we say who is more at risk than others? This is data from FIN-CV, where those on anticoagulation are in green, those off of anticoagulation in magenta, and the CHADS VASC score is being used to determine the apparent benefit. Everybody already agrees that if you're 2, 3, 4, or greater than 5, you need anticoagulation. So that's not who we're concerned about for this presentation, but rather that 0 to 1 group. Well, that's a CHADS VASC score, which, assuming that half of the people are female, would translate into a CHADS score of about 0.5. And what we see is that the risk not on an anticoagulant is still substantially higher, even in these low-risk patients, than the line in the sand drawn by the Canadian Cardiovascular Society. Other considerations: it is possible, indeed it is almost certain, that there are interactions between these risk factors. And we know that to be true. For example, being a female is not a risk factor if that's the only risk factor. But it certainly is a risk factor if you've got another risk factor. So there are interactions. This graph, or these plots, look at cardioversions less than 12 hours and cardioversions greater than 12 hours. You can see that if the atrial fibrillation has been present for more than 12 hours, the risk is much higher. It's also divided in color by whether you're a male in blue or a female in pink. Apparently, I'm not supposed to use those colors anymore. But if you can see, you can clearly see the risks in females substantially higher than the risks in males. But they all already have a risk factor because they're all they're getting older or have more. And then the very last divider was age. The older you get, the more likely you are to have a complication. And so the committee took these, the most important one, time to cardioversion. Far and away the most important determinant. So with that, we ended up with the guideline that you saw earlier, and that is operationalized in the following way. If the patient is unstable, secondary to the atrial fibrillation, if the answer is yes, do a cardioversion. If they are not unstable, have they been on an oral anticoagulant for 3 weeks? If yes, cardiovert. If they have not, we ask the question, have they been in atrial fib less than 12 hours and have not had a recent stroke? If the answer is yes, cardiovert. If the answer is no, then we ask the question, is that 12 to 48 hour group safe? How do you know? You ask, is CHADS less than 2? If it is, cardiovert. If it is not, you can't. You either have to do a transesophageal echo or wait 3 weeks. And of course, if they've been in atrial fibrillation, like the first iteration of Hercules, for more than 48 hours, then they should either have a TEE or wait their 3 weeks. This case highlights the most contentious new guideline. This is No Graham. He's a 50-year-old musician who has won no Grammy Awards. He has no history of hypertension, diabetes, heart disease. He has a 5-year history of atrial fibrillation, symptomatic with palpitations, has them about once a year, and whenever it happens, it's sustained. So he just goes to whatever emergency department of it, whatever city he's in, and says, please do a cardioversion. On this occasion, he's been in atrial fibrillation for about 4 hours, has no other symptoms. He's on aspirin. He uses pill-in-pocket metoprolol for rate control, not to prevent the episode from sustaining, but rather just so it's not quite so fast. He reports 4 ethanol equivalents daily and denies the use of recreational pharmaceuticals. Atrial fibrillation, really fast. Error on this slide. Blood pressure is maintained, but his heart rate is irregular. eGFR, please read E-creatinine clearance. I don't want to have that fight. Well maintained. So in summary, a 50-year-old, CHADS 65 factors, none, symptomatic for 4 hours, hemodynamically stable but not rate controlled. Whoops. It's the same question as you had before, with the same answers. Please vote. Is that my time to the question period or till the end?
Oh, yeah, it's about to the question period.
Till the end of the question?
No, to the question.
Okay. Very interesting. I didn't expect this many people to have adopted the new guidelines, which say this person should be anticoagulated for 4 weeks, no matter what you do. And the only way that that's true is the last 3 choices. And of the last 3 choices, this is the one patient that you get to do the immediate cardioversion on. This recommendation, the relevant recommendation, is that all patients, including CHAD-0 patients, who undergo purposeful cardioversion in an acute care setting should be anticoagulated for 4 weeks. Where does that data come from? Well, we already saw this, right? In the black box, the authors of this paper said, well, let us consider just the lowest risk patient. Well, look, the relative risk reduction with anticoagulation is 20%. That's not true, that's the relative risk. The relative risk reduction is 80%. But that's not statistically significant. Everybody else, if we lump them together, it is statistically significant, a relative risk reduction of 84%. The asterisk reminds you that that's a statistically significant result. Well, why did they take out the lowest group and add everybody else together? They did that, of course, because of an implicit bias. Their bias is we sure hope these low-risk people don't need anticoagulation. Another way to look at this same data is to say, what if we included everybody? Is it statistically significant? Yes. So suddenly you should be anticoagulating the 0 to 1s. Unless, of course, you're one of those precision medicine people. Well then, if you want a subgroup each group, in which case the first one is not statistically significant. The second one, CHADS-2, it's not statistically significant. The greater than equal 5, it's not statistically significant. Are we really only supposed to use anticoagulation if their score is 3 to 4? No, it's a complication that is related to the fact that you can't show statistical significance in every subgroup because that depends in part on the effect size and in part on the size of the population in that subgroup. So what other data do we have? I like this on the left side. So this is from the FIN-CV, 5,116 successful cardioversions on anticoagulants or off anticoagulants, former in green, latter in magenta, in CHADS-2 0 to 1 patients, divided according to the time of cardioversion. And you can see that even the CHADS-VASC 0 to 1 patients who present very early in 12 hours are still at a greater risk than the line that we drew in the sand as a Canadian Cardiovascular Society. On the other panel, just to point out that the major bleeding risk for a 1 month of anticoagulation, although it must be higher than not anticoagulating, is not sufficiently higher that we can actually demonstrate it. So the risk, we're not paying a lot in terms of bleeding. There is other indirect evidence. We talked about the anticoagulation registry a few minutes ago. Every patient in that trial that had a cardioembolic stroke had a CHADS-2 score of 0. In the Danish registry of 6,000 patients, there was no interaction statistically between the benefit of anticoagulation and the patient's start-off CHADS-2 score. And my favorite, there's another study I didn't highlight yet, the Fib stroke registry. What they did in Finland is in 3 hospitals, I think every patient who presented with a stroke, the question was asked why. Of them, 77, these were patients who had had atrial fibrillation and a cardioversion. Of that group, 77 followed cardioversion of an 77% followed cardioversion of atrial fibrillation that had been there less than 48 hours. Wow. And of those, 1 in 5 had a CHADS-VASC score of 0 to 1. So the committee has used these bits of evidence to make that recommendation, and it's created a bit of a furor with our emergency room docs. And I think I'll do that rather than the last case. So we have heard from our emergency room colleagues, 2 papers written by Ian Steele. You all know him well. He's the Canadian emergency room physician who knows more about cardioversion of atrial fib than any of the others. And he has taken exception to this recommendation. And these are the reasons. There is no high-quality data that anticoagulation after cardioversion of atrial fibrillation provides benefit in CHAD 65 equals 0. That is true. It's also true in every other circumstance where anticoagulation is considered in the acute care setting before a cardioversion. In the FIN-CV trial, the benefit of oral anticoagulation was not statistically significant in the low-risk patients. I showed you why I don't think that that's relevant. The thromboembolic complication rate is low in low-risk patients, and it's argued that it's so low as to not warrant intervention, either because it's offset by a bleeding risk, because the number needed to treat is very high, because it requires too much time, et cetera, et cetera. And that might be true. It's all a question of where do you draw your line in the sand. The Guidelines Committee does consider stroke prevention of higher value than the prevention of a major bleed. It has been argued that warfarin takes too long to become effective. Indeed, warfarin therapy, introducing it in the emergency department is a waste of time, probably. Well, probably not a complete waste of time, but you're going to miss the point. It has to be done with low molecular weight heparin and then warfarin, because the biggest danger is the next 2 or 3 days when warfarin isn't even working yet. Or you could use a NOAC, but it has been pointed out that that cost will fall to the patient in some jurisdictions, and they're expensive. There is data that suggests that Canadian doctors may be better able to select low-risk patients than those in Germany, the United States, or Finland. Might be real, but we haven't got the kind of volume of such data to overcome that which comes from other jurisdictions. The strongest concern, though, is the weak recommendation that we have made. It is weak, based on the kind of data that is available. That this weak recommendation notwithstanding, can I say the notwithstanding clause in Quebec? It's okay? Actually, I think Ontario is the only group that's ever used it, isn't it? Anyway, this recommendation, it worries our ER physicians that it carries an air of standard of practice that limits their opportunities for patient-focused clinical judgment. My view on this question is guidelines are not for people who understand the data. That's not what they're for. People who understand and are intimately familiar with the data will do nuanced actions based on their knowledge of that data, including such things as patient-focused clinical judgment. If you don't know the data, you need the guideline, in which case the fallback position that we have accepted is anticoagulation for all for 4 weeks. I'll stop there, sir.
Thank you. So we do have questions regarding this topic. So you performed TEE prior to cardioversion and it confirmed LAA thrombus. You postpone cardioversion, you initiate anticoagulation. Do you repeat TEE to confirm the absence of thrombus before the next cardioversion?
Do you? Yes.
Yes.
Yeah, so everybody knows of the Acute trial. It was the trial that actually did a randomized evaluation of the use of TEE to guide anticoagulation. It was in people who had been in atrial fibrillation for more than 48 hours, though. In that trial, the protocol was you do it. If there's a clot, you anticoagulate. Well, you were going to do that anyway. And then you wait 3 months, and then you do the TEE again. If the clot is still there, then you have a quandary. But what most do is wait another 3 months, do the TEE again. If it's still there, you have yet a third quandary, but most people are then comfortable enough that the adherence of the clot to the left atrium is sufficient that you can proceed under the last 6 months of anticoagulation.
Do you treat pill-in-the-pocket strategy the same as pharmacological cardioversion in the ER?
Did you see the picture of Dot go by? She was the cool lady in the leopard skin hat. I don't have a leopard skin hat. But that was her case. The answer to the question is we don't have a clue. Is pill in the pocket approach to getting rid of atrial fibrillation, that is pharmacologic intervention of an active sort, and some might argue, therefore the guideline applies to that individual and they should be anticoagulated. In the next iteration of the guidelines, we are going to make clear what we think of that supposition with the phrase that will go something like, we don't have a clue. It is conceivable that it is safer than what we see in the emergency department because the duration of atrial fibrillation, which is so critical to the outcome, is expected to be an hour to 90 minutes. And that's not something we've got data on in emergency departments because it takes 90 minutes to be seen in an emergency department. Never mind get to one. So next time around, we're going to say we don't know.
All right. What do you do for these patients?
So I did have a graph there that we didn't get to. If the duration is expected to be under 4 hours, I do not anticoagulate them. And that's based on a linear regression of the data that you saw from NOACs, the time dependence in low-risk patients. If you draw a line through the points that estimate at each time, when does it fall below 1.5% per year, which is 1.25% per month, at about 4 hours. But that's awfully weak data. But it's better than no data.
So let's say the patient presents within 12 hours, but also had other episodes in the days before. But the last episode was 12 hours. Would you still cardiovert without 3 weeks or TE?
So if they're...
The actual episode is 12.
That's a great question. I haven't a clue what I would do in that. I think I would probably go ahead. I mean, I'm trying to think, do we have any data on burden, right? That's what we're asking, atrial fib burden as opposed to single episode duration.
I think
you guys know any?
One point to mention here is the perceived duration of the episode by the patient is not the reality. So that type of patient thinking that he had many episodes, but the last one is 12, may be in AF for the past week with higher rates by times. So in that situation, I would tend to do TE for these patients.
I think it's notable that most of us, I think, can tell whether or not the patient knows when they went into atrial fibrillation. People like Nogram, at a heart rate of 180, he can probably tell us the second he went into atrial fibrillation. But it is true when you hover around 110 and go faster, you get symptomatic, less fast, you think it went away. That is a real problem.
There are two comments. Is this on purpose that all your patients were HAT?
What a coincidence.
All right, okay. So I'm going to go with general questions, and then I'm going to go for the look towards 2020. They're interesting questions. I go by popular. So if a patient has had one episode of AF, it's for the three of you, with no clear trigger, and a normal Holter or event monitor in the follow-up, and are they committed for OAC for life if they have CHAS 65 or more? Or is it ever appropriate to stop OAC?
So I'll answer that question with evidence of my certainty. I've had one episode of atrial fibrillation. It was about a decade ago. Lasted about 5 minutes. Intensely symptomatic. Probably the result of smoking cigars and drinking wine with my friends. Since then, but not then, but since then, I became a CHADS 1. I know you're thinking it's aged, aren't you? Aren't you? Ageists. And I do not take anticoagulation.
Did you change your friends?
No, but we all stopped smoking cigars at about the same time.
So
I think you were one of them, weren't you?
So another question, let's go democratically. This is the highest. Can you please remind us of the clearest definition of non-valvular AF? Maybe Jason?
So the way we define it in the guidelines is any mechanical valve, it doesn't matter where that valve is, that counts as non-valvular. If you have moderate to severe mitral stenosis of any etiology, then that counts as valvular. In our guidelines, we consider any element of rheumatic mitral valve disease to be valvular, and that's largely because those patients would have been excluded from the trials of NOAC versus warfarin. But hemodynamically significant mitral stenosis, definitely, and a mechanical valve, definitely. If you've had a valvular repair that works well, that's non-valvular. If you have a bioprosthetic valve in the aortic position, that's non-valvular. If you have a functional bioprosthetic valve in the mitral position, that's non-valvular by our guidelines.
You wanted to add something, Brent? No?
No, I didn't want to add to that, but I did want to add a comment to my previous answer about the single episode of atrial fib. You reminded me with your phrase, the single episode of atrial fib patients are not in any of the trials that you have ever read about. They all required multiple episodes. So that kind of patient is also excluded from the trials. And I wanted to go back to one of the questions you answered, and that is, in some jurisdictions, the one that comes clearest to mind is Taiwan. Their guideline says every patient having a cardioversion needs a TEE.
Wow.
Just to point out the importance of that form of investigation.
So to finish this session, I'm going to go through just to give you a quick update or where we are, and the next iteration of the guidelines will be in 2020. The 2020 will be a whole rewriting of the guidelines. So we've wrote the entire guidelines in 2010, and then we did update in 12, 14, 16, and 18. So we will be working. We already started, actually. And these are the main topics. Of course, it's a whole guideline. So classification and definition, epidemiology, pathophysiology, initial evaluation and screening, modifiable risk factors, which becomes a very, with the integrated approach, very popular and sensitive topic. Stroke prevention, which is a small line, but it's a lot of subtopics for that. The same with arrhythmia management, which is acute and chronic, and rate and rhythm. The special circumstances, so the device-detected AF. We talked about also the special situation with congenital heart disease, hypertrophic cardiomyopathy, and also associated arrhythmia with the flutter and other arrhythmias. So these are the working groups working on all these different topics. And as I mentioned, we already started a year ago to plan this thing, draft recommendation. We've met at this meeting yesterday, and it's ongoing work. The plan is to come to present these, this whole work next year at this meeting in 2020. So on that, I would like to thank the faculty as well as everyone in the room for their questions, and enjoy Montreal.
Jason responded. It's a weak recommendation.